All right, let's dive into a topic that is an absolute must-know medical emergency, cardiac tamponade. This is where fluid literally squeezes the life out of the heart, and knowing how to spot it and what to do about it can be the difference between a patient living and dying. So let's get right into it.
So let's kick things off with a clinical puzzle. Imagine this. A patient shows up and you find out they have a massive pericardial effusion. We're talking over a liter of fluid, that's a whole water bottle's worth, surrounding their heart. So what's your first thought? Are they in immediate, life-threatening danger?
Surprisingly, the answer is not necessarily. And this is the absolute core concept of this whole explainer. The single most important factor isn't how much fluid there is. The real question, the one that truly matters, is how fast did it get there? And that brings us right to the heart of the matter, the pathophysiology of the squeezed heart. For a second, I want you to completely forget about volume. It's all about pressure. Think of that pericardial sac around the heart like a balloon. You can stretch it, sure, but only if you give it enough time. This right here is the whole game. If an effusion builds up slowly, over weeks or even months, that pericardial sac has time to stretch and adapt. It can actually hold over a liter of fluid without causing much of a problem. But what if that fluid shows up fast, maybe from trauma or a ruptured aorta? Even a small amount, we're talking just a couple hundred milliliters, can cause that pressure inside the sac to skyrocket. The heart gets squeezed, it can't fill with blood, and that, my friends, is cardiac tamponade.
Okay, so we know the why. Now let's talk about the what. How do we actually spot this in a real patient? What does cardiac tamponade look like when you're standing at the bedside? Let's break down that clinical picture.
Clinically, you absolutely have to know the classic signs. They're captured in something called Beck's triad. And for your exams, here's a super easy mnemonic. Just remember B-E-C. B stands for a big JVP, or jugular venous pressure. The blood is backing up in the neck veins because it can't get into that squeezed heart. E is for extremely low blood pressure or hypotension. The heart can't pump out what it can't take in, right? And C is for cannot hear heart sounds. They sound really distant or muffled because you're basically trying to listen through a bag of fluid. B-E-C. Burn it into your brain.
Now, Beck's triad is classic, but it's not the whole story. The body is smart. It tries to compensate. So you'll almost always see a fast heart rate tachycardia and rapid breathing or tachypnea. The patient will be complaining of shortness of breath. And then there's this really specific, really cool physical exam finding called pulsus paradoxus. So what on earth is pulsus paradoxus? Well, it's a huge clue. It's when you check the blood pressure and you see the systolic number drop by more than 10 points every time the patient takes a breath in. Here's why that happens. In tamponade, the heart is in a tight space. When you breathe in, more blood returns to the right side of the heart. This causes the wall between the ventricles, the septum, to literally bulge into the left ventricle, making it smaller. A smaller ventricle means less blood gets pumped out, and poof, the blood pressure drops. So your physical exam is screaming tamponade. You're highly suspicious. But now you gotta prove it, right? So let's look at the diagnostic studies that are gonna give you that definitive proof. A chest x-ray can give you a clue. In a really chronic, slow-growing effusion, you might see this classic water bottle heart, where the cardiac silhouette is huge and globular. But, and this is critical, in acute tamponade from, say, a stab wound, the x-ray can look completely normal. So please never use a normal chest x-ray to rule out tamponade.
All right, now for the ECG. There is a pathognomonic sign. That means if you see it, you've found the diagnosis. It's called electrical alternance. This is where the height, the amplitude of the QRS complexes alternates. One beat is tall, the next is short. Tall, short. What's causing this? It's the heart literally swinging back and forth in that big sac of fluid, which changes its electrical axis relative to the ECG leads. It's pretty wild. So the X-ray can be a clue, the ECG can be a huge clue, but the definitive, gold standard, #1 test is the echocardiogram, an ultrasound of the heart. It is the absolute best way to see the fluid and, more importantly, to see the effect that fluid is having on the heart. It's fast, you can do it right at the bedside, and it gives you the answer. So what are we looking for on that echo? Well, obviously you'll see the black stripe of fluid around the heart. But the key signs of actual tamponade are dynamic. You're looking for the collapse of the right atrium and the right ventricle during diastole. That's when they're supposed to be filling. The pressure outside the heart is so high that it literally squishes these thin-walled chambers flat. When you see that, it's game over. You have confirmed tamponade physiology. Okay, you've done it. You confirmed your suspicion. Your patient is in cardiac tamponade. This is a true time is of the essence medical emergency. Now it's time for decisive, life-saving action. The treatment is actually pretty straightforward, but it has to be done urgently. You have to get that fluid out. The procedure is called a pericardiocentesis. You take a needle and you drain the fluid from the sac. And because of that crazy pressure-volume relationship we talked about at the beginning, sometimes removing just a tiny bit of fluid, 50, 100 cc's, can cause a dramatic drop in pressure and an immediate, incredible improvement in the patient's condition. Now, if this is a recurring problem, they might need a more permanent fix, like a surgical pericardial window.
Okay, let's bring it all home. We're going to do a super high-yield review, consolidating the absolute must-know points. This is the stuff you need for your exams and, more importantly, for your patients. This table is basically your cheat sheet. With a simple effusion, the problem is just the volume of fluid. In tamponade, the problem is the pressure. In an effusion, hemodynamics are usually stable. In tamponade, they're collapsing. The key signs for tamponade? Beck's triad and pulsus paradoxus. The key diagnostic findings? Electrical alternance on the EKG and that RA/RV collapse on the echo. And treatment? You can watch and monitor a simple effusion, but tamponade? That needs urgent drainage. Period.
All right, let's finish with one last really important clinical thinking question. You've got a patient with tamponade. Their blood pressure is already in the tank. Which class of medications would be an absolute catastrophe to give them right now?
The answer, and you need to know this, is anything that reduces preload. Specifically, we're talking about vasodilators and diuretics. Think about it. That poor, squeezed heart is desperately dependent on every last drop of blood returning to it. That's the preload. It's the only thing keeping any cardiac output going. If you give a diuretic or a vasodilator, you pull that preload away, and you can cause complete, irreversible cardiovascular collapse. Remembering that isn't just a test answer, it's a clinical pearl that will absolutely save a life.